Good evening. Welcome to the March meeting for Silicon Valley ACMSograph. Tonight, we will have an exciting presentation on XR medicine given by Laura Kusumoto. I am Alex Junkarek, Chair of Silicon Valley ACMSograph. Before we get to tonight's presentation, let me tell you about our chapter. Silicon Valley ACMSograph has been meeting at different Silicon Valley companies such as NVIDIA, Apple, Intel, and Google for many years. However, since COVID hit, we have moved to online meetings. If you have attended our meetings regularly, you know that I have said many times that we hope to return to in-person meetings soon. Well, tonight, I'm happy to announce we now have a venue for in-person meetings. Our next meeting, which I will detail in a few slides, will be in person. However, we are still open to additional venues at companies. If there's anyone interested in sponsoring us, please contact us. With online meetings, we are able to produce them at no cost. However, for in-person meetings, we have costs for items such as fees for using a room and food for a meeting. If you would like to support our effort to getting back to in-person meetings, please consider joining our chapter as a paid member. Chapter members also get an associate membership in the ACM, which has a variety of benefits. If you would like to join us and help us resume in-person meetings, please scan the QR code above. I hope to see you all pretty soon. Now I would like to tell you about how to find more information about our chapter. You can find the latest information on our chapter on our website. We also have a meetup where the latest meeting information is recorded. You can contact us using this email. We also have a YouTube channel where many of our events are recorded. If you're watching this on YouTube, these links will be in the comments and in the YouTube channel description. Otherwise, you can find this information later by typing in Silicon Valley SIGGRAPH into Google. Now I would like to introduce the officers of our chapter. I am Alex Junkarek, and I'm the chair of the chapter. Brent Simon is vice chair. Carl Anderson is treasurer. Sharon Yang is secretary. Ken Tarkovsky is a member at large. And finally, this could be you. We are always looking for more volunteers and need help in many of the chapter activities. If you like what you see here, or even if you would like something different, please consider joining us. As a chapter officer, you will have the opportunity to set up events around your interests. And now I'd like to tell you about some of our future events. In April, we will be showing the Computer Animation Festival from SIGGRAPH Asia. This event will be in person only and will not be online or on YouTube. Please check our meetup for more details. In May, we will have Klina Borklowicz talking about her work in scientific visualization. She previously directed the Visualization Program Office at the National Center for Supercomputing Applications. To see a sample of her work, click on the QR code above. This will be an in-person meeting. Please watch our meetup for details. Hope to see you in May. And now, to introduce tonight's speaker, here's Ken.
Good evening. Tonight, we are pleased to have Laura Kusumoto as our featured speaker for the month. Laura is a technology and innovation leader whose career spans spatial computing, enterprise innovation, and digital health. Her early work with Forterra Systems advanced the multi-user networked virtual environments for military and medical simulation, pioneering applications of interactive 3D for training and collaboration. Later, providing innovation services at Kaiser Permanente, she developed processes for vetting and promoting new digital tech offerings, supporting the best in class for adoption in point of care systems and piloting. Laura has led emerging technology initiatives in Meta, Deloitte, Disney, Lego, Intuit, and the U.S. Veterans Administration, defining frameworks to assess and scale AR, VR, and AI solutions in complex organizations. Today, with her company IterationZero, Laura bridges enterprises and startups developing AI-powered immersive platforms for health and well-being. Laura has served on the boards of the Virtual World Society and XR Women Global and on the advisory board of the International Virtual Reality in Healthcare Association. So without further ado, I'd like to present Laura with her presentation.
Okay, thank you, Ken. Now let's welcome Laura.
Let me get my slides displayed. Thank you, Ken. And I'm really super happy and truly honored to be speaking here with the Silicon Valley chapter of ACM SIGGRAPH. I am a SIGGRAPH member. I have been so for more than 25 years. I'm technically in the pioneers group. And I was a longtime resident of Silicon Valley and San Francisco, but I'm coming to you from Los Angeles now. And I'm going to talk about medical XR from the early days to today. And I want to clarify that what I mean by XR is extended reality, which is presented to users traditionally by a VR, virtual reality headset, or an augmented reality headset. I also embrace the use of computer screens to display 3D content and even mobile phones to deliver 3D content, although that's less immersive. So medical XR can be delivered in any of those ways. And the medical part of it means related to delivering medicine or healthcare, or learning how to do that through education. I also include the idea of empowerment of patients and consumers to take care of themselves in this. So this is going to be a whirlwind journey. It attempts to cover 40 years, over 500 companies, and many thousands of people, one of which is me. So I am, just to introduce myself, here are some of the logos of companies that I have worked with. Currently, I'm a consultant and founder of IterationZero, which, as Ken said, and we basically provide strategy analysis and program management for technology, innovation, and production, mostly in the healthcare area. I'm also the board member for the nonprofits Ken mentioned. I started my career in Silicon Valley, very proud of that, as a software engineer with a master's degree in computer science from Santa Clara University. And that became a magic carpet ride for going through many industries and areas of computing. In this presentation, the focus is really on medical applications, so I won't cover the rest of it. I won't be talking about what I did at Disney. Before we really get started, I want to ask a provocative question. And that question is, are we mainstream yet with medical XR? I was stunned recently to start seeing a slew of these advertisements on Facebook from XR Health and its partner Better Health. And it tells you that if you have Medicare, this is covered by Medicare, and you can get mental health therapy. You don't have to ever have any more pills. Wow, these are great advertisements. And they're appearing on Facebook, which of course is a very popular and mainstream platform. So does that mean VR in medicine is mainstream now? So after 40 years of development, it is starting to surface as a practical medical tool. Is this the beginning of medical XR becoming normal? Or is it another hype cycle? Let's go through this talk and see what you think. So I'm going to go through these topics with my main goal of helping everyone understand how far this industry has come. You'd never know it from the tech press, which is telling you that the metaverse is dead and that we're all being raptured by AI, including all of our investments, right? But medical XR actually is at an exciting time ripe for commercialization. So I'm going to start with grounding us all in some of the challenges that healthcare itself faces, so we can look at what some of the problems we can solve may be. I think it always makes sense to start there. And then we're going to take a very brief year of the 40-year history of medical XR, after which I'm going to talk about how medical XR works, not just as an engineered product, but how it works with human beings. It's an important part of the system. And then we're going to talk about the state of the field right now. Where are we succeeding and where are the blockers, the problems that need to be solved? And then what are some of the future directions? Oops. All right, so let's start with those healthcare industry challenges. And I do want to say I'm primarily focused on the United States and in the statements I'm going to make, but some of these issues are occurring worldwide. So I'd say there are some challenges and outcomes, and these are all selected because they are addressed by healthcare and the healthcare system, but they're all strongly influenced by the behavior of the patient. Not all of it is the patient's fault, but some of it can be influenced by them. So if you look at mental health, there's been a crisis of mental health among youth, especially after the COVID era in our country. But there's also the problem of people getting older and feeling isolated, and just the rapid change in technology that we're all absorbing is causing a lot of mental health issues. We have a long-standing issue with preventative health, often due to poor health literacy, people not understanding how health and nutrition and exercise actually work, and then they might receive some misinformation about that. But then they may also know things, but they lack time and motivation to act upon what they know. Medication adherence is a huge source of cost and injury and even death in our country. Failing to buy or take life-saving medications is very serious. Hospital discharge instructions often don't work. They are forgotten. They're told to people when they're under a lot of stress and maybe medicated, but not handling properly can lead to readmission or worse. Addiction recovery. The battle against drugs and addiction has been going on for 40 years. It doesn't seem to be getting better, even though we have better and better techniques for treating addiction. We still need more tools. And then feeding into addiction, one of the factors is pain management. And there are difficulties. It's a very complicated, difficult topic leading to suffering and sometimes addiction. So we can use more tools in that area as well. So just taking as one example, pain management. In the US, this one problem alone costs $560 to $635 billion annually. And that's in both direct costs and productivity losses. It affects about 50 million US adults, and about almost 20 million are considered high impact people who their lives are severely affected by the pain management, the pain that they have. It can cause depression, causes other things. It's a leading cause of disability. And it requires specialized care, can cause opioid addiction, and there are side effects from other medications as well. And I'm going to jump ahead for a moment and just give you a preview of, this is one of the areas where VR appears to be helpful for certain kinds of pain management. You're looking here at an advertisement for RelieveRx from Applied VR, and I don't mean to advertise it, but rather to say that this is something that is being adopted. It's FDA approved. You can get reimbursement for it. There's a reimbursement code, and it's been tested in randomized clinical trials, multiples of those, and it shows a special efficacy for high impact chronic pain management. It can take those patients from high impact to low impact in a number of weeks. And it appears to have a lasting effect as well. So that is achieving some adoption. Is it available everywhere? No, but it is very, very promising. There are also some structural challenges in our healthcare system. Those have to do with big societal problems. Clinician shortages is a chronic problem. Retirements, overwork, which happened a lot in the COVID era, burnout, and too few new clinicians in the pipeline. So as we're going through this, think about how we can help solve that. Aging population. There's nothing we can do about aging. Actually, it's a good thing. It's better than the alternative, but there's a lot of older people coming along, and they tend to use more healthcare resources, hospital stays, and so forth. Rising costs. Everybody in the United States knows the costs are going up. Insurance is going up. Medicine is becoming more sophisticated, and the cost of that is going up. It requires more and more people. So that is an unsustainable problem. There's competition to the traditional healthcare system by the direct consumer pathways, like retail giants like Amazon and CVS, concierge services being set up to reach around the traditional healthcare systems. And now even AI is getting licenses to deliver medicine to people's desktops. So that's another sort of competitor that may help some of these problems, but it's a disruptor. There's uneven access to care. So I think a lot of these problems are familiar, but it's good to think about them when we start talking about potential solutions. So let's move into the history. I am going to try to cover 40 years of history, but I promise I'm going to keep it brief. Hope to be less than 10 minutes. I'm going to include some examples of things that I worked on, and I think that's important mainly just to help you understand. I have a practical understanding of some of this stuff, but by no means was I involved in most of these projects. This is truly a history lesson here. So I'm going to start back in 1985 when VPL Research was founded in Silicon Valley. It was the first commercial VR company founded by Jaron Lanier with co-founders. And that's pretty well known. That's pretty famous. What's a little less well known is that he had a collaborator, Walter Greenleaf, who licensed all of the medical intellectual property from VPL Research and ultimately retained it. And Walter Greenleaf is pretty well known as the founder of VR, of medical XR, what we're talking about today. Then we go to 1989, up in University of Washington. The HIP lab was founded by Dr. Tom Furness, and they explored a lot of themes in VR, early VR, that turn out to be things that have been very successful throughout all the decades that followed. Looking at using VR to practice surgery, looking at VR to help deal with pain, looking at VR to deal with phobias. They explored all of those themes and more. There was a conference, and I'm highlighting a couple of conferences and journals here to show that this is a maturing industry. The conference Medicine Meets VR started back in 1992. It ran through 2016. The very first one was attended by Dr. Richard Satava, along with Walter Greenleaf, Jaron Lanier, and many other people that stayed in the field for quite a long time. So in 1997, something called Spider World was launched rather, and that was a treatment for phobia, the fear of spiders. And Hunter Hoffman was behind that. And it was really the first case to demonstrate the efficacy of immersive computer-generated VR and mixed reality because they were touching real objects, namely spiders, as part of the inoculation against that fear. So that was a pretty forward-looking application. And you can see Alan Alda here interviewing them for some TV coverage. Pain Magazine in the year 2000. Now, this is only 25 years ago, roughly. That was the first paper on VR in analgesia. And what did I talk about earlier? We talked about pain management. So VR is a powerful tool. They were just beginning to understand that then. Notice that this patient is wearing an 8-pound helmet on his head, and it was a $90,000 system. So things have improved since then. I mean, nowadays we complain if we have 2 pounds on our head, right? But 8 pounds, that would have been tough. In 2004, the first of a whole family of applications developed by USC ICT for VR exposure therapy was released. That was Full Spectrum Warrior, evolving into the BraveMind product and lots of related products. And you see here, they had really great graphics. They had, fantastic crew there creating game level graphics for this exposure therapy, which allowed a therapist to subject soldiers to realistic events as if they were happening again, and allow them to feel again what they felt, and help the therapist would help inoculate them against those reactions over time so they could have more normal reactions. That was Skip Rizzo who led that work. In 2003, right around the same time, I was hired by a company called There. There was a competitor to Second Life. We didn't know it at the beginning, but we became a competitor to Second Life. And it was a social virtual world. That's the picture on the left side of the screen here. It's one of those worlds in which everybody logs in. You're an avatar. You get to choose your outfits. You can have a house and property. You can have a dog powered by AI, paint guns, vehicles, play all kinds of very kinetic games. It had hundreds of thousands of users. My challenge that I was hired for was to take on an Army contract to take this world with its cartoony assets and turn it into a very serious training system for the Army, which is shown on the right. This was a very significant effort. It took millions of dollars at the time, and it required considerable re-implementation, not only of the art, turning the skeletons of the avatars into realistic ones, the structure of the faces, the articulation of the faces and arms, but also adding things like Humvees and IEDs that we didn't have in a social virtual world. And as you can see in the scenario on the right, the soldiers could practice with teams, and we had role players there to act as the civilians. And this enabled the soldiers to practice for asymmetric warfare, which is where the sides are unevenly matched, and quite typically you're mixing in with the civilian population, which is a very tricky thing to learn how to do. And over the years, we became Forterra Systems, and we took that same system developed for the Army and began to apply for other grants and turn it into other applications. The first one is that we ended up doing some military-based medical-related applications, including response to chem and bio attacks in the battlefield. But then we were able to translate that into civilian casualty response. We started with dirty bomb responses, but we also did some others. And I noticed that one of the people who participated in this with us as an SME, subject matter expert, Dr. Mike Aratow, had logged in earlier. If you're still there, hello, Dr. Aratow. He was one of our emergency medicine SMEs. So we developed these scenarios where something would happen in this place that we called Peninsula City, that had a town squares and hospitals and ambulances and fire trucks. So the big emergency would happen, and all the role players would come, creating this scenario, and then we would have people being able to practice their medic or medical roles or their paramedic roles. We would be able to do that on the scene. You can see in the middle picture here, hazmat response could be practiced, including triage and so on. And then in a later phase, we developed physiology simulations in the hospital so that the emergency physicians could practice providing the correct kind of medicine in the hospital setting. I do want to note, prior, in the beginning of all this, we did have over $1 million to start with, but that was still a limited budget to do all the things we did over the years. These graphics may look crude to a modern audience, but they're running on a vintage 2007 PC. They're being captured by a video program that's not that sharp either. Forterra's art department had 3 artists. 3. Well, for a while we had 4, but usually 3. And they did all of this artwork by themselves. There was no Unity development environment. There was no Unreal development environment available. There were very few 3D libraries. So they were doing amazing things with the resources we had at hand. A lot of the work was that we had to pay for was engineering to create all the interactivity that you see here. All of this would be done more rapidly today, but it's interesting to see that we were able to do it then. So moving right along in history, the first Google Glass equipped surgery was performed by Dr. Raphael Grossman in 2013. Remember when the Google Glass came out? And in looking forward a little bit today, all the things that he thought about, like de-identifying the data that was coming so that we didn't know who the patient was. And he was, sharing with students so that other people and colleagues and students could be, learning from the surgery. And, I've read an article just less than a year ago at USC. Some surgeons are doing that again for the students at USC, and they're using Meta Ray bands for this. Again, they're taking the same privacy concerns into account, but I think it's just interesting that, 13 years later, we have much less expensive available tools to do similar things. Now, some of the real heroes in this industry are the Veterans Health Administration. They are, for those who don't know, the largest integrated healthcare system in the United States, with 371,000 health professionals and staff. They serve 9.1 million veterans through a network of 170 medical centers. And back in 2016, a VA nurse in North Carolina, Caitlin Rollins, and then a pharmacy leader, Dr. Ann Lord Bailey, and others started exploring the use of VR to help their veteran patients. And since that initial spark, thousands of VA clinicians have been enabled to use dozens of applications for these veterans. As of 2026, after a lot of hard work across a very large institution, they now have some offering of VR in every state and territory of the United States. In 2019, there was a milestone that the VR surgical simulator was accredited for use in Royal College in England. And that is a very important, significant milestone, being able to use this kind of simulation to train surgeons. And back to a little bit of work that I did when I was at Meta. My job there was enabling employees to use VR in their own work. But one of the things we did, this was during the pandemic, work and life were very stressful at that time. And we wanted to do a study to see whether VR could help with that stress at work. So we put together a headset that had 6 applications for stress relief and for focus. And we put together a formal, with actual researchers with PhDs, to a formal 30-day pilot that asked people to use one of these programs. They could pick whichever they want for 30 days in a row, twice a day. And we found that there was a decrease in stress because they were asked to report before and after every time they used it. And there was a majority positive effect on their overall sense of well-being in that 1 month. That was pretty powerful. We then repeated that in 2022 with a larger cohort, over 200 people, multiple locations, international, post-pandemic, in office and at home. And we got similar results. We also were able to compare the results of just taking breaks in VR versus just taking breaks. And we found that the VR did have superior results in terms of stress relief. All right, wrapping up this history, in 2024, the Journal of Medical Extended Reality was launched. The founding editor was Brennan Spiegel, Dr. Brennan Spiegel, who 4 years earlier had written a book called VRX. And another person involved in the founding was Dr. Mark Zhang, who also founded the American Medical XR Association. So again, this is a goalpost of becoming a mature medical discipline, that there are journals and an association around these disciplines of using VR. So I'm going to move now to how does this work? How does VR work both as a device and also as a how does it work on people? I'm talking mainly about software. I'm not really covering the hardware aspects of VR in this. How does it work? That would be at a few more minutes, but I just wanted to share the architecture of Olive, which was the tool we developed at Forterra in the absence of Unity and all these other things that are available today. But the elements of this architecture that we then sold as a product so other people could make their own virtual worlds and their own scenarios are a lot of these components are still needed today if you're going to do a networked virtual world type of application. Something more closer to what we have today. I did go around looking for architecture diagrams, and really the architecture that you're going to have in your VR application is going to be very much influenced by what you're trying to do. There isn't sort of a generalized one. This one from the internet is about game VR architecture, but if you put some medical assessments and data over on the right side, you have the idea of what a networked collaborative application would look like. And those kinds of things are done, in AR in the medical field, specifically with HoloLenses. But the thing is, many AR and VR applications we have today are still single user, so you wouldn't have any networking at all, except perhaps to get content as you're using the device. So those would obviously have a different architecture. So on the left, what are the considerations you'd have coming up with your architecture? Is it single or multi-user? Are there what sensor inputs are there? The number one sensor is you've got cameras, you've got controllers, and you've got other sensors that may be there. Is it all happening on the device or networked? Some medical XR providers have decided to have it all on device so that you don't have to deal with the Wi-Fi in medical office buildings. So, that's an important consideration. Where is the storage of the 3D assets, the audio and video? There isn't that much storage on the headset itself. There's some, but a lot of applications have to be loaded. Some of them are streaming while you are running them. And also, is the device, are you rendering on the device or in the cloud? Cloud rendering is not that common, but it does add a lot of muscle to the rendering capability. Medical considerations, these are just examples. There can be physiology data analysis happening in real time or simulation for training. Medical data such as DICOM data ingestion, which needs to be translated into something that can go in the VR. Soft tissue visualization, interaction with that's not that easy in graphics. And then haptics associated with that. Biometric sensors, such as the things you have on your watch today, heart rate and or blood pressure or other biometric sensors. I did a survey. There aren't that many that are actually being used in the field today, but they're there. They're there to be used and integrated. AR and MR registration, and you have to be able to register things very precisely, especially if you're using it in surgery. And then there's always IT security. You can't avoid that. So those are some of the aspects of architecture. There are also a number of computing challenges. We're not running on 2000 PCs anymore, but it's still very constrained when you're running an application on a headset. Some people call them the phone on your face, because the original Quest 2s especially were pretty much that. They were Android phones, strapped to your face, but in stereo. They are getting better. These devices are getting much more powerful. The Qualcomm chips that are coming out are handling more of the graphics, more of the AI that you want, the networking, so forth. And there's more and more types of chips in the headset. All that said, there's still a lot of constraints in pushing, 3D into a mobile class headset. So this is a list of some of the things that have to be considered. People coming from other disciplines of computing into 3D often are surprised at all of these things, and it is pretty much a specialty now. So a good place to talk about one of our favorite subjects is with avatars. One of the things that happens when first of all, not all medical XR applications have avatars. You don't necessarily need them for everything. For example, if you're just interacting with stress relief and you're just, in a fantasy world and so forth. But for those applications that do have avatars, how they look matters a lot to people, especially when they first see it. And then people, especially like CEOs and marketing people and all that, always want them to look more realistic. And I guess that's just a human thing we all do, but that's not always efficacious. It's not always what we really want. Number one, number two, it's really hard to do. Still very hard to do. So you see examples here of different avatars from over the years. The There.com and Meta Horizon Worlds and Engage are basically all kind of social. Engage is more professional, but it's for a lot of people. I think it's very interesting to compare the USC ICT Battle Buddy with Inner World. Both of these are actually being used for behavioral therapy. USC's Battle Buddy is a very well modeled, very realistic avatar that talks to you on your phone. It's really well done. And by the way, the USC ICT curriculum and everything develops incredible avatars. They have a lot of technology that isn't necessarily been even commercialized yet. They have really good technology. But we go over to Interworld and you go, and some people look at that at kind of face value and say, why can't you have better avatars? But you know what? These avatars work for what they're trying to do. They have a peer support group, mental health, virtual world, where guides come and help people talk with each other about common concerns they have, whether they're addiction or maybe dealing with grief. And they organize all of that really well. And everybody's anonymous. So it's been, pretty popular, for example, with veterans, because they may have some issues they don't want to talk about with anybody who knows them. So there have been a lot of tests and pilots done with this, and some actual serious research. And they're just finishing up a randomized clinical trial that will also show the results from that. Back to a little bit more of history, but it's relevant when you talk about avatars. These avatars are, a little bit, slightly not that detailed, but they were animated and their faces move and they do have legs, which not all the modern avatars do for performance reasons. And you can see it in this picture. This was a research that was done with Stanford and Kaiser Permanente in practicing a routine that they called nurse knowledge exchange. They were teaching nurses how to communicate at shift change, and they found that they wanted to see if they could scale that training by putting it into virtual learning. So you can see on the right-hand side where we're doing the research, researchers in the back, nurses in the front. They have laptops. They have headsets on that are basically for their audio. They are using their voices. And they're able to play both the role of the patient and actually we have a role player playing the patient, but the family can be a nurse, one of these nurses in training, and the nurses can be played by the nurse. And through role playing, they learn kind of, how to communicate on both sides of the equation. So they, you can see that the scores showed that there was pretty much equivalent learning between doing this kind of training in the real world versus doing it in the virtual world. And, that was considered a pretty good result, especially considering that back in 2007, some of the nurses didn't yet even know how to use a computer or a mouse. So we were able to get them to equivalent learning with this technology. So transitioning a little bit into, why does VR and AR, why does that work for humans? One expert on this is Walter Greenleaf, who's stayed in this field all this time. He was a neuroscientist when he encountered VR back in the 80s. And he points out there's a number of mechanisms in the brain that immersive systems are able to tap into. And we're not going to go into the science, but they have to do with sense of presence and context. When you are truly immersed in VR, you feel like you are there. You're in that virtual place, and you have a memory of being in that place. And it sets a context in which things can happen that you're going to believe. So there's a very strong suspension of disbelief. You also, when you're there and doing things, you are forming muscle memory the same way that as if you were doing things in the real world. And this works easily with procedures, but it also works with talking to other people, talking to avatars, and so on. So as a result of that, you retain, you learn and you retain. And there's been a number of studies that show the after effects of that, comparing, say, video learning to, or learning on Zoom, comparing that to learning in VR. VR provides greater retention for the amount of time that you spend in it. So why does that have to do with medical XR? Almost everything that we are doing in medical XR is training the brain one way or another. Either teaching people things, teaching them to think differently, feel differently. It's all has to do with affecting the brain. And there have been research studies also that show people are far more engaged with the content that they encounter in VR than they are in other modalities. So that leads us to something that I've been working on, partnering with Walter Greenleaf and also our immersive producer, Christian Groyle, on the topic of how can we take the power of and frameworks from literature and from films and the best games and apply them to immersive? How can we amp up the content to use everything we know about storytelling in this new medium? And that has caused us to look back at the hero's journey, originally popularized by Joseph Campbell, who was a kind of a philosopher, but he came up with this book, Hero with a Thousand Faces, back in 1949, and observed a standard hero's adventure where a hero is called to the adventure, goes into a special world where they encounter monsters and mentors and helpers and dangerous things that happen to them. They learn how to get past that, and they are transformed and they come back. You see this pattern repeated in films and also in interactive games. But we also see it in immersive now. And I've got 3 examples here of software where, or content where that is being framed, but it's a little bit different in immersive. You are now the hero. The patient is the hero, going through these different adventures. So the 3 examples very quickly. One is the idea of doing physical therapy in VR. The example I've chosen is Emergo Labs. They allow the physical therapist and the patient to be in a virtual room together as avatars, and they have such good body motion tracking that the therapist can provide can do an assessment, can provide exercises that the person's supposed to do and watch them do it without leaving their office. Now, typically there would be an in-office visit to start this, but this does enable people to do physical therapy outside of the office. The next one over is the VR exposure therapy that we talked about before with USC for the care of PTSD. And that's under the care of a therapist that uses this tool to expose them to really dangerous things or like the things that had happened to them in the past so that they can help to recover from that. And then the third example is patient education. At the extreme, you can go inside yourself, right? The idea here, this was the mock-up of an early thing by Housecall VR, where they go inside the pancreas and they have a discussion with clinicians there so that you can learn from them why it matters what you do, and then they can also animate things that happen to you, like if you eat a piece of cake or you eat a steak or you take some medicine. These can be animated while you're in there so that you now are empowered as a hero to work towards your own care. So going quickly now to the state of the field that we're in, there are literally hundreds of offerings out there, several hundred of them actually. I might group them into consumer clinical care, which is taking place in the healthcare system, and then training and education, both of doctors and clinicians and of patients. And we're going to go pretty quickly here. There's a lot of material, but I did want to say that, again, the Veterans Health Administration has been very generous with sharing what they're doing with the rest of the world. This is a list of a sample list of the active use cases that they have that they are using today. Everything from pain management, which we talked about, down to phantom limb pain, fall. You see assessments here being able to assess if somebody's at risk for falling, creative arts therapy, stress reduction, which we've talked about, neurological assessment, and then also things for the employees, wellness, education, training. So you can see what a versatile tool they have found this to be. Also on the side of success, let's look at what other systems are using VR and AR, XR in their practice. VHA is the biggest one that we know of, but Mayo Clinics have done some work in this area at scale, Cleveland Clinic as well, and Cedars-Sinai has done quite a bit of work, including Dr. Brennan Spiegel being based there. And some independent providers are coming to provide things both to the healthcare system, but also to go around it so that people can perhaps get these treatments on their own. So XR Health, which was the basis of the advertisements we saw earlier, Waya Health, Mind Immersive, and then DoxyMe is one of the big telemedicine platforms, digital telemedicine, usually video, but they also do have a VR offering. Education is really taking off. By the way, there are no hockey sticks here. All of this stuff is growing. So when I say taking off, it's growing. Nightingale College, they now have 10,000 students with headsets at any given time. They've been greatly expanding their nursing education program. Nebraska University has a massive simulation center, which has AR, VR, holograms, all of that, and they're using it at scale for their students, medical students and nursing students. Ohio State University is another place where every nurse is required to have a VR headset. And University of Manitoba has survived COVID and beyond because they figured out how to give some of their training and preparation for nurses in VR. So there are some blockers against success. I did a workshop with Bob Fine of IVRA with 12 different organizations that were already using VR at the scale of hundreds to thousands to 10,000s. And we asked them, what is stopping you from using VR more fully in your healthcare system or in your franchise of providing healthcare devices, whatever it is? And these are the issues that they called out. Interestingly enough, we did some voting so that these are ranked in terms of priority from their point of view. Interoperability and standards were the top for them because they cannot scale when you're putting one app on one headset, and for the next app you have to get a different headset, and they're not interoperable with each other. Also, the user interfaces across all these things, every single app has a different user interface that you have to figure out. So more blockers to success. This one's kind of a sad one. We have a very unstable industry. It's very old, 40 years, but continues to experience a lot of churn. And, look on the left, the things that have been discontinued or are discontinuing. We just heard in the last week that Meta Horizon Worlds VR is being shut down. A lot of creators are very upset about this. It doesn't really affect medical XR that much, but it's a signal that's causing all the news outlets to tell you that the metaverse is dead. Medical XR is not dead, but, it just creates that vibe. All these other, the penumbra immersive healthcare system being shut down a couple of years ago affected thousands and thousands of users. And that was, for physical therapy, stroke rehab, a lot of patients not immediately affected. They could continue running them, but they were never going to have an upgrade. Microsoft HoloLens discontinuing has had a profound impact on a lot of the offerings that are out there, and they still don't really have a perfect replacement for that. So these have been things that have really interfered with the progress of the industry. And then on the right side, we have new things coming. Android XR is an operating system just for XR for multiple devices. And along with that, Samsung has a new headset out. It's a bit expensive, $1,700, but it has some good specs. They're going to follow up with AR glasses, and they're using Android XR on all of them. There's this company SNKE that's putting out an AR headset for the medical market. And there's Snap putting out their new specs this year, et cetera, et cetera. And then dozens and dozens of smart glasses are coming out or already out. Probably some of you are already wearing them. That's a big thing that's happening as well. So we have a lot of disappointments, a lot of encouragement happening at the same time. It's kind of a swirl. So what are some future directions? There are many possibilities, but I want to focus a little bit on this new acronym I found. By the way, that's part of our industry. We're always coming up with new names and acronyms. Way back when I was a director of artificial reality for a company. who knows what artificial reality is anymore. But XR is being combined with AI, and this is one of the ways to express it, XIAR. And the reason why I depicted glasses is that's one of the modalities that it's being and going to be delivered through. So what does that mean for medical XR? I just delivered a talk on smart glasses at IVRHA. So I had, just some characterizations of AI glasses versus AR glasses. The AI is more, text display. If you have a display at all, it's more about the cameras and the audio going back and forth, and then a little kind of flat display that can be on there. But amazing things can be done with them, including the, watching surgery in real time. It's already capable of that. And there are literally dozens of manufacturers that are coming out with these in Europe and China and the United States. And then AR is kind of a light version of the AR headsets. It has some depth sensing. It might have it has a 3D spatial display, but not with the high fidelity that you have that you would have with a full-on headset. And it will allow mixed reality, some navigation, and some of the smart glass AI capabilities as well, like translation and captioning and facial recognition, which of course is controversial but could be useful. So these are coming, and they do have some potential applications for medical XR. If you're thinking about using AR and AI wearables, these are kind of some of the trade-offs you have to consider. Virtual reality interferes with your workflow. You're going to have to stop. You can't continue doing anything else while you're immersed in VR. Whereas with these AI and AR wearables, you will be able to keep going. You see a near future where both the doctor and the patient in an encounter, they're both wearing these glasses and they're doing different things with them. And we have to have policies to protect privacy in that situation, but they can also do very useful things for us. There's some other integrations of AI and XR. I'm not going to try to be exhaustive. I think you can use your imagination, but AI can enhance the training that we do in Immersive by creating simulated patients who can talk, and you can role play with them. You can deliver bad news to them. You can have training scenarios that have variations. You can have AI coaches. You can have AI helping with assessments, helping with procedures, practicing procedures, planning procedures, educating patients about procedures, clinical assessment. Recently, there have been a lot of things happening in ophthalmology, being able to do eye tests and vision field tests in VR instead of the big clunky machines they normally have had. And those are starting to become accepted. Gait for fall risk assessment, even measuring emotions through your eyes and facial expressions for behavioral health. So there is on the right-hand side a diagram here about the idea of, there's a theme now of humanizing AI, that's one of the things that XR and 3D will be able to do. And an example of it is the Cedars-Sinai's Zaya application. Sorry for the confusion, AI, XR, Zaya, yes, it's confusing, but Zaya provides AI for behavioral therapy. Zaya is kind of a therapist that people can talk to. So here's a diagram of what's basically going on there. And it works very well. It's being implemented at Cedars-Sinai, at UCLA Health, and also Mayo Clinic. And it's available directly to the public too. Working on some of those blockers is in our future as well. So working on interoperability, we have to be doing that. I'm very fortunate to have worked with the Veterans Health Administration on their Made for Healthcare Immersive Guidelines, which distilled about 10 years of their experience with VR and using it with patients into a set of guidelines. And I'm currently working with the Virtual World Society to turn that into something we can propose as a standard for using healthcare, using immersive in healthcare. And I also wanted to commend the mobile device management solutions for trying to seek interoperability at some level and for ease of management and applications across whole networks of devices. We already have this for mobile phones and for tablets and PCs. We need to have it for headsets too. And perhaps the biggest challenge of all is really mastering the institutional and organizational requirements that are needed for any new technology to be accepted into actual healthcare. So I won't go through this, but there are a number of institutional, milestones that need to be passed for any technology. And if we just go back to that example of Applied VR, they have had their FDA approval. They did get CPT, they have identified CPT codes, which are the diagnosis codes that are used. There is a CMS reimbursement code available, and they have some insurance companies that are willing to actually do the reimbursement. But then the organizational part is hard too. Clinical workflow integration. On the right, there's kind of an abstract picture of that clinical workflow. Adding anything new to the medical workflow with the overworked, super busy doctors and the system built around them is extremely difficult. AI is having an easier time of it because it's a system that can be integrated with the systems they already have more easily. Whereas with VR or any of these things that involves a piece of hardware, it's kind of an interruption, at least in the beginning. There's procurement, compliance, and my favorite, IT security. So I'm going to leave you with this. I think part of the future is not just making healthcare and supporting healthcare and clinicians and health systems, but it's also really empowering the consumer. And there's a lot of different ways that Immersive can do that. Notice on the left hand, my AI generated picture of over-the-counter medicine in the future. They hand you a headset with the treatment that you need, and you can take it home and use it. That's probably not the way it'll really be distributed, but it's a sweet idea, and it's something that's already happening in some places where the healthcare systems are using it. On the right-hand side, humanizing in quotes AI. It's interesting that Cedars-Sinai very consciously chose a robot humanoid instead of a human-looking humanoid to represent their psychotherapist in the virtual world because they didn't want to over-anthropomorphize it. And in the middle, it's the old dream of the internet. Well, would it bring us together? Would it enable us to build communities so we don't feel so isolated, sense of belonging, mental health? This would apply to mental health. This is an actual picture of a meeting that I was in with a bunch of people. We went from here to explore part of the surface of Mars, and then we came back, all as avatars with legs. And I know these people the way I know friends. So we have a chance again to build something that would support our community health by building communities online. And with that, I would love to hear what you think. I've said enough.
Well, thank you for a wonderful presentation, Laura. I was, as I was listening to you about how the results of the VR training were very effective, so that the results were indistinguishable from someone who was actually watching it. That reminded me of a meeting that we had in, I think, 2004 at Stanford University Summit, where we had a chance to experience doing surgery with VR glasses and haptics and everything. And it seemed like like it was all ready to go, but and to take over with education. Yet it seems like it hasn't been moving that fast. Can you comment on, you said we're not at a hockey stick, but we're growing, but we're losing some of the technology, but yet gaining some. Is this a monotonic increase in use, or is it kind of wavering?
Yeah, I think in the medical healthcare area, it has been steadily growing. just a lot slower than we hoped and thought, but it is steadily growing. The setbacks on the side of hardware have cut back, some uses, but people are generally not giving up. They're finding other solutions. And I often advise them to think more about the application you're trying to do than the actual solution you're choosing, because I think these changes in technology are going to continue. So we really need to find, base things on standards as much as we can. There are XR standards for graphics, and some people are using OpenXR and all that to help insulate themselves against these, future shocks, because these innovations will continue. But I think we are still advancing, especially now. I think, 15 years ago, there were some real discontinuities. And also we were trying to do things on PCs, which don't have really the same immersion that you have with this hardware. I think what's the wind that's blowing in our direction now is these wearables that are becoming consumers are starting to adopt them, which makes them less expensive, easier to use, and all of that. And of course, there's all the problems of putting those in an enterprise environment. But I think the wind is blowing in the right direction. It's not a gale. It's still just kind of we have an army of people that are walking in the right direction. We do not have them all on rocket ships.
Okay, that's good to know. We do have some questions. Do you want me to read them, or would you like to read them? Bob Lavagna has a question. Wouldn't XR devices add device friction and setup overhead? Also, what's their long-term adherence and billing pathway like?
Right. So yes, they do add friction. And when I talked about that workshop that I had at IRVA with the 12, people, organizations implementing at scale, that is also one of the things that they talked about. But there are people that are starting to overcome that. And I think the real lever to think about right now is, what is the value of the application? Anytime you're asking people to step back from what they're already doing and put something on their head, that is going to be friction. That is friction, no doubt. I don't care how easy it is to use, it's still friction, because you've got to put something on your head. It's almost like people don't even want to click on a mobile phone, right? And they're not going to want to put something on their head. However, if the value delivered is high enough, they will do it. And that's kind of where we are with these headsets right now. And it's why I also encourage people to look at the smart glasses coming down the pike, because some applications, certainly not all the really immersive ones, but some could be done with those. And by the way, other wearables as well. And that may add up to less friction. But I think really the answer to that is make sure the application delivers enough value that you're motivated to use it in spite of the friction right now. Long-term adherence and billing pathways, I think that is going to depend on which application, but I'll base this on some of the more successful ones. Going back to Applied VR, they have a set program that lasts a certain amount of time, and once it's done, it's done. And I think it's 6 to 8 weeks. When it's done, it's done. And so the long-term adherence is how much has the person learned and internalized for managing their pain over time. They have done a follow-up study at 6 months. They've done a follow-up study at 2 months. These are different studies, but in general, they are showing some adherence and also some benefits compared with other interventions. That doesn't mean it's universal. That doesn't mean it's for everyone. We're still learning who these interventions are best for, but there's some real promising information there about adherence. The billing pathway, like I said, the hole has been poked open. There are codes that can be billed. CMS has some codes to use, and the next thing is getting both the clinicians to adopt it and also the insurance company to agree to reimburse for those codes. So that's kind of where we are. So we have a smattering of organizations that are doing this, and they're seeing results. I think another example was, XR Health that I showed the advertisements for. They have figured out how to get Medicare to reimburse for their mental health treatments. So that's a pretty big thing. It doesn't mean, I mean, they're just getting started and getting people to adopt it. But so I think what you hear is that these were kind of early days, but it is happening.
Thank you. Bob also has another question
Yeah.
about full body tracking. What's the consensus of the benefit of that through motion capture or wearables, or versus just XR headsets and accessories for
Yeah, that's a
cases?
big one. So, um, the example that I showed with Emergo Labs, they are, PhDs in computer science, and they've figured out, and biomechanics and all that, and they have figured out how to do this body tracking without any special hardware. It's consumer off the shelf headsets with their controllers. So they do use the controllers and the headsets. However, if you want great precision and all of that in certain parts of the body, probably you would need some sensors and you get different kinds of data. Those can be implemented, I would say, in clinics. They would be difficult to implement at home unless the value is high enough. So if there's a specific treatment, this is where there's kind of a curve. If the treatment really works, and the whole kit together, the motion sensing and the headset becomes a medical device that's approved and reimbursable, then it's all worth it and that'll work. But if it's something you expect a doctor's office or a consumer to buy and adopt, I think you fall off there in terms of people being willing to do it. So I think that's really where, what's the value? How important is it? Is it important enough to go against all of the barriers to using an extra piece of hardware? I can see the next question. The most promising but unexplored areas of academic and clinical research in medical XR. Most unexplored. Most promising but unexplored. I'm so I think on the one of the things I do want to mention a name here, which is Dr. Susan Persky at the NIH. She's devoted the last 10 years of her career primarily to doing research in medical XR. So I would strongly recommend that you take a look at the work that she's done and the themes that she has been exploring. I think some of the more unexplored areas really have to do with being able to do a lot of the research that's been done so far is sort of the first crop of research, even though there's been about 10,000 papers published. So maybe they have been kind of small trials or small groups, and we actually just need to do more of what we've done and branch out. One of the questions is, okay, so something works for 50 people or even 500 people. Who does it work for better? What are the assessment that you would do of the patient to determine whether this intervention is good for you or not, for that patient or not? Another question that's not very well understood is a little bit about the content that I started to talk about. We're looking at the hero's journey, but actually what content works well in medical XR? What are the requirements for it working well? We talked a lot about this when we were working on the immersive guidelines at the VHA, but not a lot of research is behind that. And this is not research, but I think another area that's relatively unspecified and unexplored is accessibility in XR. Accessibility is a big plus and a big minus in XR. It hasn't been researched well. We don't know how do you make an accessible VR environment for people with lower vision or lower hearing? How do you compensate for those things? Most of the environments are not captioned, right? Why not? Oh, by the way, there isn't even an API or something for captioning that works on all these different environments. So that's something, that people haven't done research on. And if you go to the 501, accessibility requirements, I think that's the number. It talks about fonts and printing, and it doesn't talk about anything interactive. So I think that's a big area. But I think I would love to be able to refer that question to Dr. Susan Persky, to Dr. Brennan Spiegel. I would definitely look at the Journal for Medical XR, and you can see where all the research is coming from. Are there others? Does anybody have comments on the future of this, and or I wonder if anybody here has tried any of these things?
If you have, please type something into the chat, the questions and answers, and uh, we can turn your mic on. Looks like Bob Lavagna has got a question.
Hey, hi everybody. I just typed in my question. Well, thanks a lot, Laura, for answering the questions. I had a quick one about XR devices being applied in intensive care environments, right? And specifically around reducing physician workload. I looked at a application like this over here, and I heard mixed reviews on this from a number of people. Primarily physicians and but also folks who are building out applications for XR, medical XR. Just want to know your opinion on this.
Can you be more specific, or would you want to speak more generally?
Um, you could generally would be fine also. I guess the concern was this, that there's oftentimes in environments where you're juggling copious amounts of information. When I say you, I mean physicians as the primary user. They have lots of information they have to go through, and it's not necessarily easy or ergonomic for them to visualize a lot of this information. That's where XR devices can kind of be kind of very helpful. And there's certainly some companies out there building for this. There's companies building out entire devices ground up. There's folks building out XR apps for this, but there's been some. It's difficult for, I guess, certain environments, clinical environments, to adopt this kind of workflow. Yeah.
Yeah, so I think you talk about ICU, or even if you're talking about an OR environment as well, those are very extreme performance environments where you have to be careful about the foreign objects that are brought in. So having things be sanitized and sanitary is a very important part of it. Also being able to design it so that the information that is provided is supportive of the workflow with a minimum of interaction. So for example, voice interfaces to avoid needing to use your hands, or some kind of being able to effectively read the room and interact with or get data from devices around the room. That's where you need to get more specific. I think one strong piece of advice that is extremely important for anybody developing XR for that kind of environment is that you must work with clinicians. You have to work with clinicians. If there's not a clinician on the team, you're probably not designing for them. I'm not a clinician. I'm a tech person. And one of the biggest lessons I've learned is that you need SMEs on your team, and you need to work with them from the ground up. That's the only way to really understand that environment and build for them. I think once you do understand the environment, you can find mitigations for the sanitation, the inconvenience, if you can provide data that really can support their workflow and give them things that are harder to get otherwise.
Can everyone hear me?
Yes. Hi, Mike.
Hey, Laura, how's it going? Yeah, great talk. Thank you so much. That was real enjoyable and very comprehensive. I just wanted to emphasize that some of the points you made, which were really poignant. One is that if you want to do VR or XR work where you involve patients, that harking about the reimbursement strategy is paramount. I mean, it's dead in the water unless you get the insurance companies to reimburse you. You get a CPT code, and if necessary, FDA approval, like Applied VR did. In fact, we piloted Applied VR in my ER. She's 15 years ago, and one of the things, and emphasizing the workflow that you were just talking about, and I noticed also, was they used Gear VR at the beginning.
Oh, wow.
Yeah, and so we couldn't even, it was very hard to put the device on the patient, and then you had to sort of explain a little bit to get them going, and especially if you had to do it in a different language, it was challenging. And you know, you didn't have broadcasting at that time, which would have really helped. So little things like that really add to the workflow, you know, workflow friction. And if, like you said, if it's you really workflow is another primary concern, and if you can't fit it in and it's not faster, better, cheaper, then it's just not going to get used, even if it's great technology.
Absolutely true. And I think adding to that, this is Dr. Aratow, everyone. He's an expert in emergency medicine, probably a lot of other things, including technology adoption. I think another aspect of it is that the whole team is affected if somebody's bringing a device into an environment like that. And you know, managing the device is a thing. Like, okay, if you've got one of them and you're piloting it, that's one thing. But if you really want to use it regularly, you might need to have 30 or 50 of them. And those have to be managed. Those are some of the problems that BHA has resolved for certain applications in certain places. And again, I think it's driven by, wow, we see this thing works where other things are not working for us. So we're continuing to do that. Other things that don't pass that muster don't win. And to your point, Dr. Aratow, they don't have to worry about reimbursement because they are they provide their own reimbursements within the organization. So they're less concerned about, they do want CPT codes, but they're less concerned about the CMS and the reimbursement.
Yeah, that's definitely a unique environment, but not the only one. So, right.
Rick, I see you there. Did you have any comments on this? I know that you're also an expert in this area.
No, Laura, that's a great presentation. Thank you very much, and agree very much with what Dr. Aratow has said and what you said. I did have a question which I put into the Q&A about
okay.
what what does the ideal healthcare headset look like? What should it look like 5 years from now, and what kind of changes can we make in the current hardware to spur, to help spur adoption? I mean, that's critical right now. You had an entire slide on folks that have left the industry, but you've got new people coming in. So I mean, what would the ideal headset, do you think, look like over the coming years that would help accelerate our efforts in healthcare XR?
Well, if we can dream, Rick, by the way, I'm just now seeing the Q&A window. If we can dream, I think that we would make something that is modular so that you could have a baseline, say, a pair of glasses that lets you to have certain basic functions, probably AI and 3D and video and audio delivered to your head, and then be able to add things. That's my dream. And it would also be easy for you to change the size or order the size that fits you, and the eye correction that fits you, so that you would have this device and be able to customize it to your professional or your personal needs. Because right now the headsets are kind of one size fits all, and I don't think that's the way to go in the future.
How about a module that satisfies FDA requirements across a number of different applications? It would save a lot of us a lot of money and a lot of effort.
Absolutely, absolutely. And that would be a module that you could, attach to or add to your thing that's holding the thing on your head. Call it glasses. Exactly. That might change. There already are some of these smart glasses have multiple layers. They have the regular glass layer and then they have a display layer on them. So that concept is there, and maybe that could grow. And of course, there would be some chips that would have to be added. The current smart glasses, the AI glasses, have 15 to 20 chips built into the glass. It's incredible. That could be augmented, right? Over, especially 5 years from now. But I love your idea of FDA approval across the board, and let's also add standards so that we know that we can count on a certain resolution, that we can implement certain level of performance, that we can expect certain connectivity, all of that to be able to, and content to be some of it interchangeable between different models of these head-worn things. So that we don't have to rewrite it for every platform.
Yeah, no, absolutely. One device that can work across rehabilitation, behavioral therapy, operative planning, it would save everybody a lot of effort, and I think it would accelerate adoption rather rapidly, as you've alluded to.
Right. So maybe it's time to write the reference design for this thing and get it built. We know a couple people who are embarking on trying to do this. I just wonder where the funding for it will come from.
Yeah. Yep. Critical issue.
Yep. There's a question from Julian. Hi, Julian.
Hi.
Wondering about the psychological effect on professionals from all the misery they see. Oh, is it the same when they're in extended reality? That is an interesting question. When you speak of misery, you mean the illness, the pain, is that what you mean?
Yeah, many. For example, what Mike Aratel spent a lot of time on was phantom limb treatment. When you think about all of the mental problems that the vets have in the VHA, and the professionals are dealing with this all day long, every day. And I imagine, and of course, Mike will have an opinion on this, but they have developed techniques of dealing with this. The thing about using XR is that, as I said many years ago, virtual reality isn't. And so the visual presentation you get is enough different from actual reality that I wonder what happens when you're trying to process all of this stuff.
I do imagine that number one, experiencing these things in extended reality is not the same as reality. You're right about that. You can create equivalencies in training, but what does it really mean if you're in a more intermediated environment and seeing that kind of misery, say in behavioral therapy with avatars? Does that distance you from it? I don't know, but I think the real misery that professionals see is a lot more intense, probably.
And can I also throw in I wanted to throw in Weizenbaum's comment, way back when about how people started treating Eliza as an actual person.
Yeah, and people are starting to treat AI as though it's a real person too.
Yeah, I think actually that you can there's some transference there, and there are some VR applications, right, that help people be empathetic, and so
Yeah.
I just think that if you can teach empathy to people, you can also simulate, if you're saying, the exposure to misery, and then also how to deal with it and how to compartmentalize it, which is what a lot of providers have to do. So I think there is some application for that.
On the topic of empathy, that's controversial whether you can treat it or train it or not. But there is empathy training there for providers. I don't know about its effectiveness, but I do know that people are experimenting with that. We also had the research that was recently done, published last year. Somebody was comparing delivery of bad news among actual doctors and to the advice that AI has given them about how to deliver the bad news. And, they took some random normal people and had them rate the responses that the AI had versus the doctors, and they thought that the AI was more empathetic sounding. When asked, though, would they rather see the AI or a real doctor, they chose the doctor. That's good, I think. We had an anonymous question too. Could you talk more about patient data privacy and protection, especially with body tracking, eyes tracking, and other possibilities? What if your data gets hacked? like my medical data has already been hacked. How are patients protected? That's a deep one. I kept mentioning IT security, and that is huge when you are adopting these devices into a healthcare system. I would segment this between getting it really accepted in a healthcare system versus rest of world, because the rest of world doesn't have those kinds of protections. And in a way, that's part of the reason why the FDA gets involved in some of these things too, because your security and your safety and your privacy are all wrapped in together. But talking about data privacy and protection in a major healthcare system, that's sort of, it's not job number one, but it is table stakes for anything that you do. And the systems are set up not to let a single bit of information get out. I'm not saying it never does, but they're set up to never let anything get out. They are set up not to be hacked. Doesn't mean they never will be hacked. They're also set up so that the human beings that are encountering that data are practiced, trained, practice again and trained again of how to handle that information, because that often is the weakest link in any cybersecurity system is the human beings, right? So I'm not a clinician, I'm just a tech person, but both in Kaiser Permanente and even as a contractor, not even an employee of Veterans Administration, I had to take the training on how to handle this information multiple times a year. So so that's what they do a lot, and there's a lot of other legal stuff that they do. And so when a new device comes in, an information technology device, it is subjected to severe scrutiny. And this is one of the reasons why a lot of health tech products are a lot more expensive than you thought they would be, have trouble getting into the system, is because they don't know how to integrate with that system, and in general, IT security won't talk to them either. So it's a difficult thing to get in. So once they're in, they're supposed to be highly protected. Super important to the organization. I mean, going just a step further, everyone working in a Kaiser Permanente or a Mayo or a VA, they know that one bad thing could cause really bad headlines and could hurt somebody. They don't want that to happen. So they do everything they can to avoid it. But data can get hacked. Healthcare systems are vulnerable because they have valuable data. I used to wonder, why would anybody hack a healthcare system? Well, it's mostly money. There's a lot of money flowing through them. So by getting hold of somebody's stuff, you can, blackmail them and things like that, or just do harm. There's also evil in the world. So I'm answering this very, very generally, but you're talking about body tracking and gaze. So we already have the problem that on your mobile phone, your typing and your behavior with your mobile phone, it's been shown it can identify you. When we get to VR, it gets worse because we have even more information about where you're putting your eyes, how you're holding your head, perhaps how you're talking. So that is a general consumer device problem. It gets worse with smart glasses also because you're seeing things, right? And so everybody who's thinking about applying these has to think about all the consequences of those things. And in healthcare, most of all. So that has come up in these VR and healthcare reviews. And, are there things that we're not protecting by accident? That maybe the new technology is breaking the rules and we don't really know it because we haven't really thought about it. So I think those things are being discovered and worked on. That's sort of where we are as far as I know. I would also say in most of these systems, nobody's putting headsets on their networks. It's hard to get a headset on a network right now. I don't mean to say nobody, but it's very, very difficult to get a VR headset on anybody's healthcare network right now. And that is a blocker for them because if you could at least provide notes of what had happened with the patient to the electronic health record, that would help the doctors a lot to adopt this, because they don't have to have a nurse transcribe it or transcribe it themselves, etc. Right? So that's a thing. Are we out of questions?
So
Yes,
have we solved? Oh, go ahead.
go ahead, Carl. You started first.
Have we solved most of the let's say bad side effects, with the fast enough frame rates and everything on tracking?
Oh, no.
Uh,
No, we haven't, but they're getting better, and I think that does have to do with frame rates. It has to do with the design of the content also, and also screening people. So if VR is going to be used in its current state in healthcare, the clinician who wants to use it really should be assessing the patient to make sure that they're going to be okay with it. It won't, and that might involve testing them with the content to make sure that they can hold the headset. I mean, some of the patients are really old and maybe infirm and might have vision problems, etc., that make it difficult for them to put on the headset. I'll give you an example. My father and his wife, several years ago, I brought home one of these things, and his wife tried it on. She's, wow, this is amazing. Oh my God. This is the usual first VR experience, mind-blowing thing. My dad put it on. He could not stand it. I don't know what he didn't like about it. He could stand it. He just took it off.
Yeah.
So he would have failed the test for using it for healthcare, right? Now, again, it's getting better. The graphics are getting better. The headsets are getting better. Everything's getting better. But we have to look at where we are right now and assess to make sure that the person you want to use it really can handle it.
Mhm.
I think the ratio, this is just my personal opinion, it used to be 20% of people had these kinds of problems. I think it might be down to 5%. I'm making that up. I don't have any data to support that, but just my observation of people using it today with the Meta Quest 3 and stuff like that, that the problems aren't as bad as they were. And when I was at Meta, my team helped 10,000 people get into headsets. And we encountered the friction that you all are familiar with. How do I do this? How do I put it on my head? How do I get it started? All those things. And there was a certain percentage that would have some kind of nausea or dizziness or just feeling hot. And those are all real. We had to deal with them. Either they would overcome it within an hour or so, or they just would have to limit their use. In some healthcare applications, they advise on the label per se, use this only in sessions of 15 minutes. Use this only in sessions of 30 minutes. Those are kind of what they're advising to make sure that people are comfortable with using it. Julian had his mother try a Google Cardboard. Funny. Any more questions, thoughts?
Just going to say this was an awesome presentation. It stimulated quite a bit of discussion. I think we went something like 30 or 40 minutes over time, but it was I loved it. I thought the interaction was great.
Awesome. Well, I'm really happy to see the folks that are here. Maybe someday we'll meet in person, those of us who haven't met yet. And yeah, I welcome contact from anyone who wants to continue the conversation.
Okay, and if you want Laura to help you with your burgeoning VR business, she's available for consultation at IterationZero.com, right?
.io.
.io.
Yes.
All right, thank you, everybody, and have a
Thank
good
you.
night.
Okay, thank you, Laura.
All right. Thank you, Alash. Thank you, Ken, Carrie, Brent, and one other person, but I don't see her here. So thanks, everybody. Good night.
Night.
Good night.
Good night.